a vision for public policy and governance in South Asia. So the ideas and the academic work that will be expressed during the course of the keynote address are the intellectual property of Professor Sharma and myself. However, if there is any deficiency or any mistake during the course of the presentation, then I declare that the responsibility is solely and entirely mine. So to begin with, I would like to thank the Department of Sociology, Fatima Jinnah Women's University, for organizing this grand and path-breaking conference. I would also like to thank the Hudson Tillotson University, United States, for partnering with the FJW and for organizing such a good conference. So I would begin with the keynote address. I would be sharing my screen now. Okay, one moment. Okay, is my screen visible to everybody?
Yes.
Okay, so this is
yes.
the slide.
Yes,
Okay.
yes, it is visible.
Okay, thank you so much. So like I said, the keynote speech is based on a paper that we wrote titled SDGs and Health and a Vision for Public Policy and Governance in South Asia. So we began with the assumption that health is of very importance nowadays in today's world. So not only today, but even 2000 years ago, then health was still a very important issue in society. So Herophilus, who was the ancient physician of Alexandria, of uh, Alexander the Great, he once remarked that without good health, then art cannot flourish, there can be no development. So I would dare say that this statement still bears relevance today, which was made in antiquity 2000 years ago. So recognizing such importance of health, the United Nations in 2015, they adopted the good health and well-being as the goal number 3, the sustainable development goal number 3 in the list of SDGs. Now, this was not some random decision of the United Nations General Assembly. SDG 3 and its 13 targets, all the targets, there are 13 targets. It was built upon 2 central pillars. The first was the past experiences which the United Nations had got under its Millennium Development Goals, which was practiced up to 2015. So, and then after that, there was a long series of consultations as a part of the post 2015 development agenda. So various experts, various countries, various stakeholders were considered, they were discussed about what should be the path of development after 2015. And as a result, health was included as SDG number 3. So in this context, what we decided was that we need to analyze the health policy initiatives of various South Asian countries. Why? Because policy analysis is very much important, because without policy analysis, we cannot assess the drawbacks and we cannot advocate the necessary reforms. It will also allow for us to appreciate the good initiatives and allow for upscaling them and learning from them. So again, it is also of more importance to developing countries, because in developing countries in South Asia, including India, Bangladesh, Pakistan, all of them, the people are very much reliant on public healthcare because they cannot afford private healthcare, which is managed by the private sector. So because of the large amount of people who are living in absolute hand-to-mouth conditions, public healthcare is very much important, and that is why health policy analysis is also important. So for the course of our paper, what we did was we focused on 3 countries. We focused on India, Pakistan, and Bangladesh for comparative assessments and for making our argumentative statements. So why these 3 countries? Because these 3 countries, they make around 95% of the total population of the region, and they also contribute to 95% of GDP of South Asia. So we thought that they represent a good chunk of the region and it would be appropriate to take these 3 countries. Of course, we also refer to some case studies of some other few countries, But these three main countries were considered for the course of our arguments, for the course of the paper. And then based on this, three countries, we made thematic analysis based on the targets identified under SDG 3. So if we look at SDG 3, there are 13 targets. So these 13 targets, they are aimed at various subheadings. For example, SDG 3.1 has to do with maternal health. SDG 3.2 has to do with infant mortality. So a series of related targets. We have grouped them under particular headings, and we have organized them based on a theme which we have identified, and we have not conducted any sort of country-based analysis, because we believe that thematic analysis will help in developing a pan-South Asian worldview. So the themes that we identified were reproductive and child healthcare, diseases and epidemics, and the last theme was COVID-19 to a One Health approach. So when we look at South Asia, then like I said, SDG 3.1, it aims to reduce global maternal mortality ratio to less than 70 per 1 lakh live births by 2030. So this is the target which has been set by the SDG list by the United Nations General Assembly. So if we look at South Asia, the achievements are like this. The trends that are going on according to recent data. So for India, the maternal mortality rate is quite high. It is at 113. For Pakistan, it remains at 186. And for Bangladesh, it is at 173. So this is data from 2019. For India, the data was released only in 2021, but the data set is from 2019. So if we look at this cursory data, then we find that these are still very high numbers when compared to the target, which is 70 per 1 lakh live births. So there is improvement. These are improving trends, because before this 2019, the numbers were even higher. So these are improving trends, but these are still numbers to worry for. So what we did was we looked into the issues of why the maternal mortality ratio is not decreasing as we want to, as we expect. So we first look at the policy initiatives that have been taken up. So policy initiatives in these countries, they have been mostly to increase institutionalization of deliveries via temporal on-the-spot care and incentivization. So meaning that, for instance, in India, they started a scheme called the Janani Suraksha Yojana, basically meaning the mother protection scheme. So what this scheme did was that for women who deliver in government institutions or government hospitals, and even in recognized private hospitals, they would be given cash incentives. For example, 5,000 rupees, 7,000 rupees, like that. So this mentality, the attitude behind this, the rationale behind this was that the government thought that if we give them cash incentives, then the people will automatically come to the hospitals and they would do institutional deliveries. And they also believe that this would help in decreasing the maternal mortality ratio. And this has been successful. It has helped in increasing institutional deliveries. For example, if we look at a few case studies. So there was a case study in the Dera Gaji Khan, Punjab province, Pakistan. And the case study was on very low income women, basically very poor women. And they were given maternal vouchers, which are incentivization methods. So they were given these vouchers and they were studied, they were tracked, and the findings were that there was an increase in institutional deliveries. So people came more to the hospitals to deliver with the help of these maternal vouchers. So the researchers, they suggested that these programs must be scaled up. So this scheme was conducted only in Dera Gaji Khan region. So they recommend that this scheme should be applied to all over Pakistan. Likewise, in Madhya Pradesh, in India, a study found that the aforementioned Janani Suraksha Yojana, it helped in increasing institutional deliveries by 42.6%. So yes, it has helped this incentivization of deliveries. But what we argue is that there is a need to go deeper, because this is not enough. So this demand-led temporal schemes are not enough, even though they are useful in the immediate and medium term. Yes, it is useful. It has been useful, as we can see from the previous data set. But we argue that we need to go deeper into social issues that have a bearing on the maternal health, that prevent women from coming to the hospital. It is not just the lack of facilities. So we need to look at the underlying social realities. So I will give a very simple example. South Asia is a very patriarchal society. So in South Asia, what happens is that women are expected to be the main caregivers of the children. They are expected to provide the main care to the children. So there is a close link between the maternal health and the infant health, not only during the time of delivery, but after and before the delivery of the children. So what happens is that since it's a very patriarchal society and women are the main caretakers of children, there is a close relation between the daughter-in-law in the family and the mother-in-law in the family when it comes to the course of pregnancy and during delivery. So the first point of contact, of inquiry, of consultation, I would say, of a pregnant woman is basically the woman in its own household. So I was saying that the first point of inquiry, of consultation, of seeking advice in a South Asian patriarchal household is the woman in her own family. But on the other hand, what happens is that, as we can see from the various cinematic portrayals also, that there is a deep-seated irrational animosity between the daughter-in-law and the mother-in-law, which has been portrayed in various Bollywood and Hindi and even Pakistani movies and serials also. So if we look at this situation, that means that the daughter-in-law or the pregnant woman is left in a dilemma. So when I approached my field study area in Manipur, which is which is on the extreme eastern side of India, the women expressed that the mother-in-law, most of them, they were very disinterested in their health, and to the point of neglect. So what the point that I'm trying to make is that we need to look into issues which are not apparent, but which are deeper, which are deep-seated social issues in order to address the issue of maternal and child health. Now, moving forward, there is also a need to correlate the goals of SDG 3.1 with other goals. Like I said, that there is a close link between the maternal health and infant health. So instead of looking at the targets individually, we need to correlate them. We need to think of them as a single target. And that means the need of convergence of schemes. So there is a need of convergence of health, nutrition, poverty alleviation, and even the planning departments. So for instance, in India, the central planning, which is carried out for women and child healthcare, is conducted by two ministries, the Ministry of Women and Child Development and the Ministry of Health. So there is a need to bring convergence between these ministries. For instance, also in Pakistan, after the 18th Amendment, I think, the health has been delegated as a provincial subject. And there is also a central ministry which has been revived. So there is also a need for this vertical level of close coordination. This is needed in order to bring coordination, holistic implementation, planning, and also to prevent duplication of efforts. Because one ministry might be running a similar program, the other ministry might also be running a similar program. That means funds are wasted, the efforts are being duplicated, and it is being multiplied. So we need to bring holistic planning and effective implementation as the way forward. This is our suggestion for this first thing. Secondly, moving forward, we did a case study of HIV/AIDS, and we found that there is a significant improvement when it comes to diseases in the region, the uptake remains very low. So policy initiatives regarding HIV, we analyzed them, and we found that in the case study of HIV/AIDS, despite the prevalence of free entry retroviral therapy, ART therapy, there is very low uptake.
So sorry for interrupting, Mr. Prakash. Kindly, could you please briefly do with your presentations, because we are just having lack of time, please.
Okay, okay. So
Thank you. You have
so
next 5 more minutes, okay?
okay, okay, thank you. So basically, what we did was we did a case study of HIV/AIDS, and we found that the uptake was low because of the lack of access in the region. And then we suggested the need of a regional platform for health. Now, South Asia lacks a properly functioning regional platform for health. So, why is it needed? Because we need to start from a regional level of planning. We cannot just go and adopt EU's vision of policy or any other region's health policy, because South Asia presents a very distinct socio-political and geopolitical entity. So that is why we argued that we need to provide a regional platform for health. For instance, in 2020, Pakistan hosted a SARC conference when it came to the COVID-19 virus, and it was very successful. So we argue that such initiatives should be properly mandated, they should be properly organized, and they should be formalized more. So we argue for revitalization of such initiatives. Then moving onwards, what we did was we argue that today is a very changed time. From 2015, times have very much changed, and now what has happened is that COVID-19 has happened, and several other zoonotic outbreaks, Ebola, so many viruses, Zika virus. So we argue that there is a need to rethink global health based on a One Health approach. So One Health approach basically means that we need to look upon health of not only human beings, but also the health of people, plant, animals, and their shared environment. So One Health approach basically means an interconnected approach to health, looking not only at human health, but also at animal and plant health. So this was started around in the 1800s by Rodolphe Virchow, but however, it has found more prominence today because of the COVID-19 pandemic. Now, South Asia is very much, the One Health approach is very much important for South Asia because it is a hotspot for endemic and emerging zoonotic diseases. Even COVID started from China, which is very much close to South Asia geographically. And secondly, a large population are engaged in subsistence agriculture, and they also live in close proximity with animals in conditions of poor hygiene. So we argue for a One Health approach in South Asia. We argue that we need to adopt this approach. We need to formalize this approach. And then we do a case study of what initiatives have been taken up in South Asia. So we basically find that it is mostly done by NGOs, and the role of government is very minimal when it comes to One Health approach, and it needs to be increased. This is our argument. So these are all the case studies that we have analyzed. The India has set up an expert panel in 2020. WHO has also set up a One Health high-level expert panel. So we argue that there is a need to look at these reports, and the countries in South Asia, they need to finalize their role. They need to clarify their role in adopting a One Health approach. We also argue that there is need to involve the One Health network, which is established under the World Health Organization as an avian influenza center, and its One Health hubs. It needs to be revitalized, and it needs to be involved in the policy planning process. So that is our argument. So our conclusion is that we have provided a broad-based vision for governance and policy reforms in South Asia. But this paper or in this work, we do not address issues of incidental health such as road accidents, tobacco addiction, and health issues from accidents involving chemicals and hazardous materials. So these are also targets which are included in SDG 3, but we have not included them because it was not possible to analyze all the minute details of SDG 3. So we have included the main contents of SDG 3 in our policy analysis. So we hope that this work, this presentation, and the paper will help in serving as a template for further research activities, and it will also ignite national and subnational level studies that would help in knowledge addition